having me here today. I'm Aljerian, and I think that we should start by just getting to know each other. I know you know each other, and now you know who I am. But maybe we can start by getting to know you guys. You want to start? Do we go clockwise or anti-clockwise?
Either way would work.
It looks like the camera's anti-clockwise. So let's start with you.
Sure. My name is Zoe. I'm an undergraduate student. I'm in my 5th year studying immunology and infection.
Wow.
My name is Don, and I'm a physician. I'm an MD. So I'm doing my Masters of Medicine here. So this is my final course.
Wow.
Yeah, I'm finishing my Masters soon.
Yeah, he's from
Sri Lanka.
Sri Lanka?
Sri Lanka,
Yeah.
And he knew some very famous people there.
Oh.
Yeah, so Arthur C. Clarke.
Arthur C. Clarke. He knows Arthur C.
Wow.
Clarke personally. So, yeah. Pretty
So if we need anything.
yeah.
But he's dead, but...
No, I mean, if you want to know about him,
Yeah.
you can find out more about Arthur C. Clarke through Don.
He's a conceptual,
Physicist.
physicist and astronaut, astronomical things, a lot more.
Excellent.
My connections aren't as impressive, but my name is Caitlin. I am in my undergraduate degree, majoring in biology, minoring in psychology, and hoping to be a dentist one day.
Oh, that's
and
amazing.
Maybe do some research with autism or with gerontology, so with older adults.
Yeah. Yeah. And then the less, I guess, education you have, or the less years you spend in institutes, the less doctrinated you are. So you have,
Right.
you can think out of the box easier.
You're freer.
Yeah.
Right?
My name is Ryan. I'm in my 2nd year of neuroscience, and that's pretty much it.
Yeah.
Yeah, nothing much.
No, it's all amazing, and it's nice to have this, I guess, different type of background, because then we can ask questions that I never knew were there, and try to answer them. And I knew from last time, I did have some questions that kept me thinking, and I did improve my knowledge after getting all these questions, because sometimes you miss things that you think are just normal from your. Okay, great. So I called it the final consultation and the future. And the future is another point that this course gave me, because I never knew I would give something about that. But this course is geared towards that. So I was forced to think about future, because I was just thinking about what should I do today. So that's another amazing thing I gained from thinking about this course. I call it the final consultation because for any human being, this is definitely the final consultation. You may get a referral when you're alive. When you're born, you get a death certificate. But then when you die, you get a death certificate too. But the last time any physician would be able to give you a diagnosis or a consultation would be after death. And so at the end of the presentation, we should recognize autopsy as an option as part of your end-of-life discussion and the final consultation. And at the end, we'll be familiar with the different ethical issues in the postmortem period, because they are different than in life. In life, a lot of our consent is by just responding, really. We don't need to sign a contract or anything. Just if someone talks to you or asks you a question, you respond. That's sort of a consent. You've sort of a social agreement that you're willing to participate. But in death, the patient cannot, or the human cannot speak back, as you know. At the end of the presentation, you'll be familiar with possible future directions of autopsy as I see it, or as far as Google told me what the possible options are, right? So we'll start with the first third of our presentation. At any time, just stop me if I am unclear or something is abbreviated but not explained. So end-of-life discussions, postmortem exam or examination PME means postmortem examination, and it's interchangeable with autopsy. The way I view autopsy is the same way that the diary of Anne Frank explained her ordeal living during the World Wars era or time. And so her description of her diary was, I want to go on living even after my death. And I thought that was clear, or that would be a clear message for an autopsy, is that you would want these diseases or developments or changes that happen to your organs be documented, be diagnosed. So a clinical, I guess, in a clinical way, it is like a diary of the diseases that, or the changes that happen to your organs. But also you continue living by offering this information to, whether they're trained pathologists or training pathologists or medical students attending, they can learn and they can go on with this information forever. So so similar to a diary, we're able to learn from the autopsy. So it's a diary of life. So the reason it's Miss Piggy is because our rounds in pathology are called pig rounds, the pathologist interest group, right? So pig. And so that's why Miss Piggy is there. I don't know if you know is it the Muppet Show, or is it?
Yes.
Yeah, the Muppet Show.
Muppets.
Yeah. So the Muppets. So she's I guess one of the famous pigs in entertainment. The reason is that I found when I put in to see with one's own eyes, this popped up. And so Miss Piggy is very dramatic, very loud, and I thought this would fit explaining what an autopsy is. An autopsy means to see with one's own eyes, so autopsis, right? Your own eyes. So what does that mean? That means when we examine the organs, we're able to see with our eyes directly, knowing what a normal organ looks like, what an abnormal organ would look like. So if you know that a normal looks like a certain pattern or color, and if you see something that's off, then that is abnormal, and you can either describe it or biopsy it and maybe take a look under the microscope. So you can understand the mechanisms of disease, confirm a known disease, maybe discover, if you're lucky, a new disease, and describe the mortality and morbidity related to this patient. I use the word patient, but legally we're not supposed to use that word because they are no longer persons and therefore no longer patients, but they are humans and they are deceased. But legally they are not patients. So we are able to teach medical students, residents, and non-pathology residents that attend with us, such as some of the radiology residents do rotate in autopsy, and of course future pathologists. So what do we do in pathology? So as I said, we need to get authority, and in this case authority is from consent. So the family will give us consent to examine the deceased. And then safety is the safety of the individuals examining the body. So we take our PPE or precautions regarding the not getting infected or not getting disease from.
So can the person still get a funeral?
Yes. Yes.
How does that work?
So the way that the autopsy developed with regard that delay, so the delay is approximately only 1 day. So that's as far as delay of funeral arrangements. Many times that delay is probably, or sometimes needed because people don't live in the same city or the same country even anymore. But so that's the first thing. The second thing would be the incisions are made so that they are usually masked by the clothing that someone would wear for a funeral, or not wear, but would be put on the deceased. So usually the incisions are below the collar, so it's a Y incision on the chest, and then the abdomen, and then the head incision is retroauricle, so behind the ears. And so when you're in a casket or on a table, the incision is usually masked by your hair, and usually it's on the table itself. You will not be able to see it. The funeral homes also resuture the body.
I know you were saying patients weren't the correct terminology. Just out of curiosity, what was the correct terminology?
The deceased.
The deceased.
Yeah. Legally, in English common law, once you die, you're not your personhood is not your person is gone, right? And then, so as in all of medicine is based on history. Medicine is history, right? That's what medicine is. Regardless what specialty you go into, you still have to go back to the history. That's the king of diagnoses. And then imaging and laboratory tests, usually in medicine, we put those on different lines. I put them on the same line here because many times imaging and laboratory tests are already done and they're part of the history. And then sometimes you would need them before you do the examination so that you do not miss anything. So when you do your examination, whether it's the external or internal examination, if you already have information from the history, imaging, or laboratory tests, you will not miss examining an organ in a specific way. So in medicine, we call what we call a physical examination. Many people in the community would just say physical, right? We call an external examination in autopsy, and then because it's external to the body. And then in what surgical examination, I say, I describe it as, is that we call an internal examination. I say surgical examination for the non-pathology residents and non-pathologists because they will understand that we're going to make an incision, as you asked already. So we know that to access the organs, we need to make a surgical incision, right? Because if you just say internal examination, people may not understand how you're going to see the organs. But when you say surgical, most people will understand that there's a surgical incision and therefore you gain access. And in the end, we perform, we put this together in a report, we communicate the findings to our colleagues that, or to the family directly, and we make recommendations if needed. So we did talk about safety and personal protective equipment. We won't go into too much detail, but it's to protect the pathologists from disease and the assistants from disease. Autopsy worksheet, we'll go really fast, just give you an idea what this is. So basically, like in any medical chart, we have the patient demographics, we have who attended the autopsy, who's the pathologist, who's the resident, and then if there's any restrictions. So if the family said no brain examination, we won't do one, or if they said only heart, or if they said only lung examination, we could do that also, because this is a, as I said, a consented examination, and not one required by law, which would be done at the medical examiner's office. And then we take down, according to...
why is that the family consents and not the person themselves?
Yeah, so the way English law works is that once you, even if you left it in the will, the executor or the next of kin or whoever is alive has personhood, and they would need to follow up on these, whereas, so they would need to consent. Whereas the person that has died no longer has personhood, they cannot consent.
But so if the person said no, then that means no, right?
If the person that died
said no before they died?
Before they died, they said no.
Yeah.
If the family wants an autopsy, and they don't want to follow, their choice supersedes the deceased, unless another next of kin says no. Because the personhood is not available anymore.
Yeah.
And if there's any suspicion, can we proceed with the
So,
without
suspicion of consent or suspicion of cause of death?
cause of death?
No, sorry, excuse me. So if there is anything related to the Fatalities Act that we, like in Alberta, or the Coroners Act, let's say in Ontario, so that case would go to the coroner's medical examiner's office.
Oh.
And the medical examiner doesn't need consent from
Okay.
anyone. They have the Fatalities Act, and according to that Fatalities Act, if the disease or if the manner of death fits the criteria of the Fatalities Act, they authorize the examination. They don't need consent or permission from anyone.
Oh.
The Fatalities Act is already the authorization.
Oh.
Yeah. So, and then we list if we need to do photography, cultures, electron microscopy, research, toxicology, radiology, anything, we just document it. And then we start the external exam as a head-to-toe exam. And then we can also use the diagram to note if there's anything on the external you would like to make note of. We do the internal exam, as I said, we do the Y incision to enter the chest and abdomen, and then we examine each organ on itself. First we start with the body cavities, then we start with each organ system, so the cardiovascular, then the, what happened to the respiratory? It must be on the page before. How do we go backwards? This way. Yeah, so here's the respiratory system, so the lungs, so first the heart and the vessels, then the lungs, then the digestive system, so from the mouth down to the anus, and then the genitourinary system, so kidneys, ureters, bladder, and then...
Sorry, are you going to do it with a pen or do you use it in a system?
Oh, this is actually, yeah, so here is, this PDF is in the computer itself, and we just type it in. And then you can type it directly into the system, or you can type it into this and then transfer it to the system. I just took a picture of it so that we could look at it. We still do have the paper format, which many do, especially for the diagrams. But I think I worked in places where even the diagrams and that were electronic, like on a tablet or on a, yeah. And then we give the summary of the diagnoses. But in the end, all of it is electronic, no matter what route you choose. And then you put down your main findings, your sections that you've taken, and then just the list of the weights, and then the list of the samples that you've biopsied. So another way that I like to explain autopsy. So in this, the painter, I think in the 1800s, I'm not sure, I'm not good at history. I looked it up once or twice, but the information within 15 seconds is evaporated. But every time I look it up, I'm amazed how genius this artist was. And here it was labeled, "The nurture truth lies in a well, having been killed by liars and actors," trying to express the community's objection to how, I think at the time, politicians were preventing journalists from printing or expressing themselves freely. And this is how I view the autopsy. I view the autopsy is that information has died with that body. So the information is not available to us unless we do the autopsy. And then you can see why there's a mirror or a lens floating in the well, and I'll talk about that a little bit more. So now truth grabs the mirror, right, and highlights and then she can reflect. So truth can reflect light onto herself, right? And that's how the autopsy, you can express all those hidden diseases, all those changes that were not clear during life, you're able to express it. And the reason I like the mirror that the painter used is because when I guess Dr. Solas was training, maybe, did you use a mirror? Did you use a mirror
On
generated
the microscope itself, we had microscopes with a mirror like that, but we were no longer using
No longer.
Yeah.
Yeah. But that's Dr. Mahmoud Khalifa in Toronto had one in Sunnybrook had one. I think he's in Minneapolis now. Had one in his office. I think there's one also in front of the Starbucks. If you on the first ground floor,
Right.
if you look to the right, I think there's an
Old microscope.
there's an old microscope there, and so the mirror reflects the light onto the slide,
Right,
and that sheds light onto the diagnosis,
right.
and same as the painter used, and so now the information is now outside of the well now, so you're able to extract that information that would have been buried, or would have been, and so that now is no longer submerged. So similar to the original microscope, now we still shed light, but it's not sunlight, right? And so now we can see what's truly going on. So in this case, we've removed, so the head would be on this side, the legs on the other side there. And so that's sideways, right? So your lungs, the heart is now taken out of the pericardium onto the side, covering the right lung. Here's the left lung. This is the posterior surface of the heart. This is the liver here and the stomach. So now you see with one's own eyes, right? It's not an image or a picture. There's nothing blurry. It's full HD, right? You can see it without any technology. And then we measure the organs. Here I'm measuring the left ventricle. So we don't need to guess. We don't need to use different, calculations, right?
Do you put the organs back before it's like sealed?
Yes. Yeah. And then we take samples, so we can process for microscopy or other tests that were, like you can take cultures, you can take. And then, so this is an example of a worker compensation case where the wife wanted only to see if the person had, why is it escaping my mind? Asbestosis.
Yes. Yeah.
Asbestosis. So if you compare it for the last case, when we removed the chest wall, we could directly see the lungs and heart. But you can see in asbestosis, because these people had to work in conditions that had asbestos in it, the lungs the pleural plaques became so thick that you can no longer see the heart or the lungs. It's completely encased, just like I said to the resident, just like your phone there, right? It's protecting, but here it's not protecting, it's restricting the lung completely. Yeah. And under the microscope, that's why I like to say the light reflects, because they want to, the companies don't want to give everybody that has plaques, right? So we need to reflect that light onto the microscope to see the asbestos bodies, right? To prove that this is actually asbestos and not something else.
So you said that.
Oh, actually that's iron, but the fiber is within the iron. Yeah.
The wife wanted to see if it was the work's fault.
So to get worker compensation, so I'm not a lawyer, but my understanding is to get worker compensation, you would need to prove that your disease is related to your work. And there are many jobs that dealt with asbestos as I think an insulation. So I think maybe if they build buildings or pipes, or I think even if you work in ports and this kind of thing, you might have had inhaled asbestos. I don't think it's used anymore, right? But and so once we take you can see the size of these. This is a nucleus of a macrophage here. So the fiber is in between the, you can see in between these beads. They call them beads, right? Or they think they similar to beads. And then this one, not because I'm amazing, maybe I am, I don't know. But you can see we got the cut of the iron so that the fiber is directly transected. It's obviously luck, right? Because no one can do that. But you can see how small it is.
These are your works?
What?
These are your results?
Oh, these, yeah, this is the same case.
Okay.
That case. And you can see the macrophage engulfed it, right? It looks like a rosary, or in our culture we call it misbah. It's used like for people to remind them how many times they did blessings or something.
This might be more of a legal question.
Okay.
So, if someone was an organ donor, and then like their parent or like someone else was like consenting for like, oh, I want to look at this certain organ if they had a disease, what would come first in priority?
If they both want organ donation and they want autopsy, right?
Yeah.
They want both.
Yeah.
The organ donation will take priority. As from practice, that's what I've seen. Yeah. So in the last case, I think 3 weeks ago, by the time you get to the autopsy, there's not many things to see, maybe just the esophagus. Another case, someone died and we found like post-mortem changes, or what we thought were post-mortem changes, and we took a biopsy of the heart, and we found all these dark spots during the autopsy. And then when we looked under the microscope and did immunohistochemistry, it turned out to be melanoma in almost every organ. Historically, this person did have melanoma, I think it was 2 or 3 years before it was treated completely and resected, but it decided to come back. It was in every organ. The brain, the heart, the lungs, the adrenals, the kidney, the liver, everything we biopsy. Again, with the microscopy and amazing results that we received from autopsy, someone was being treated for a pneumonia that would not heal. But when we took sections of or biopsies of the lung, we found that it's actually a form of multifocal mucinous adenocarcinoma. And you can see that it lines the alveoli, similar how the paint in this room has lined this room but not destroyed it. It lines the alveoli, but when you look at it at very high power, you see that actually all of these are tumor cells. Some of them have that, what they call a signet ring, where the nucleus is pushed to the side, and then the cytoplasm is full of mucin, so it looks like a ring. So sometimes in medicine, we're not always familiar with the presentation or the results of the imaging, and some of the laboratory tests are not 100% accurate. This is a case where, in this case, we took a biopsy of from the lung, the pulmonary artery, and in this case, we did a MSB stain, Marsh's scarlet blue, and in this case, you'll be able to see the red blood cells in yellow, the fibrin in pink, and then the platelets are the paler areas. I'll get to what this means. Another tiger-like or zebra-like pattern, similar in a different stain, but not as striking. I did a immunohistochemical stain, which shows you that there are in fact platelets, a CD61 stain, And these remind me of, or these are the lines of Zahn. This is Dr. Zahn that identified what clotting looks like. So what is an antemortem or a real clot? And for me, I'm not as sophisticated or as smart as Dr. Zahn, but if you look at when you're flying back from Calgary, you can see the farms just near the airport. They have these lines of their crops. It looks like lines of Zahn to me, but I don't think to anyone else other than me. And it also reminded me as a kid when they came out with the PB&J that was in one container, so they look like lines of Zahn now to me. And then similarly, that stain that we talked about, the farm had a little pond, and interestingly that stain also has a little pond here. This is actually a nerve, but it looks similar to, so those are both my pictures that I took. One from my microscope and one from the plane. Just some more, my fascination with all these stains, showing the same thing in a different way. And this looks like our jelly over here. So that's what pathologists do. They dream of food all day because nobody feeds us. In another case, I'm just highlighting how this stain shows contraction band necrosis in the heart, in myocardial infarction.
How do you stain something more than once? Because only like double stain.
Oh, well, that's why the lab hates me so much. But you ask for a new slide, and so they go back to the block that you took. Remember when we took tissue?
Yeah.
That's put, and that is processed, and they make a paraffin block or a wax block out of that. And then every time you ask for a stain, they have to go back and they have to cut it again.
So it's not the actual same one, it's like different.
It's the same biopsy,
Yeah.
but it's a different slide.
Yeah.
Yeah, because the biopsy is like a half a centimeter thick, but the slide is like 3 to 4 micron. And each time they have to do extra work. So for them, they agree with you. You can be an advocate of the lab in hatred of these people that order too many stains. I think we'll jump a lot of these stains and get back to I think the idea itself is just showing how it's difficult on a regular H&E stain and how easy it is on a specialized stain. And then some stains, they can show the scar in blue, like an MSB, or like a MOVAT will show the scar in yellow. I'm just reiterating and stating how important microscopy is in the post-mortem period. Here you can see an infarction. And I did a C4D stain that block stains the myocardial cells, signifying that there is an acute MI there. Which is more of the same. Here's just showing the liver, and I think there's a better picture there that shows how the liver is congested because the heart is not pumping properly. And in this case, there was an abscess, and you can see on the H&E, if you look at this macrophage here, and you do a gram stain, you can see the macrophage is full of bacteria, right? So the gram stain, gram-positive bacteria, which we also cultured from that abscess. So if you do another stain, you could see the bacteria, and the first stain you could not. So death delights to help the living, meaning that these diagnoses, the training that is available, the diagnoses will help maybe the family, will help the community, will help the trainees. So we maintain quality of patient care by comparing these antemortem and postmortem diagnoses. We develop, modify efficacy of treatments. Are these treatments doing what they're supposed to be doing, or are they injuring different organs? obviously teaching medical students, non-pathology residents, training of future pathologists, and the death certificate. Many people forget that these morbidities and mortalities are all going to be diagnosed properly, and therefore the vital statistics for your province or state will be accurate. And instead of guessing from the history what is the diagnosis, you will be able to have a pathological diagnosis, a gold standard diagnosis, and therefore your vital statistics will be correct. And then when you base your budget on your vital statistics, it has more merit there, right? Because if you base them on a suggestion clinically, then it's not as accurate. And so that's why vital statistics is very important. Public health, community health, vital statistics. And so this is how a medical certificate looks like. And then ethical issues. We touched on many of these ethical issues, including the forensic versus clinical autopsy, the clinical autopsy requiring consent of the family. Also, they label them in English law as next of kin. And also why the forensic cases, because of their, usually there's an act like a Coroner's Act or a Fatalities Act like in Alberta, which grants authority to the Chief Medical Examiner to examine human death in different cases. So the Office of Chief Medical Examiner is a required autopsy, it's not a suggestion, whereas the clinical autopsy is a requested autopsy by the family and their clinician. And the extent can be full or partial, so there are families that sometimes say, we don't want the heart examined, let's say. Or they do want only one organ examined. Sometimes we talk to them and explain that we may not be able to get a diagnosis from that organ. Sometimes they agree to do a different organ, or they disagree and do not want the autopsy. So what are the... Yeah?
Can you reject to do the autopsy? Let's say they want to, but can you say that there's like no point, or like you just don't want to? Like what gets priority? Like what you want to do, or what they
No,
want?
like that is like the family, like we provide a public service, and we have social health care in Canada. So if the family needs or requests and they're a clinician, they need an autopsy, the pathology department in any province or in any hospital, they should be able to provide that service. And so that's my specialty. I've never said I will not do it. However, there are cases where, let's say, if the body is completely skeletonized because of postmortem changes, you need to explain to the family or to the clinician, and they will explain to the family that there's no tissue to examine, right? Or that the results may be limited. And a recent example, the family wanted only the liver examined, and I explained that, you know, the likelihood, given that another organ, which was the lung in that case, had the larger disease or larger burden of disease, that we should examine the lungs. And so the clinician explained to the family, I didn't explain directly, and they said they asked if they could do a full autopsy, but it wouldn't take too long. And it differs probably half an hour to an hour, the difference. And so they agreed to a full autopsy after that. Yeah. And it was good because actually when we examined the liver, the radiology did show that there was something in the liver, but we didn't find anything, any disease in the liver, even after microscopic examination. So that was a good call. But even if they said we only want the liver, I would have done it, but I would have explained prior that we may not have a result. Budget constraints is always an issue. Alteration to medical education. So as you know, I trained in an older system where we went from department to department to learn, whereas now we learn in a, what's it called? Do you know what it's called? Oh, okay. I think it's called, like the new system, they call it a modern education, or they call it a, so you do system-based, I think it's called system-based. But you don't go to a department. So you don't learn pathology, but you would learn, let's say, genitourinary, and within genitourinary you would learn maybe a little bit of pathology, but there's no big focus on like the traditional teaching of pathology.
Yeah. So like when I entered the medical college around like 2014, so then they revised the syllabus. So now it's a module system. So module system. So we learn about system. So they begin with the anatomy, then the pathology, then the pharmacology. So everything done by like that.
Exactly.
But earlier it was like the whole year they are going to the pathology department.
Exactly.
They are learning about like the whole human body in like a helicopter view.
Yeah.
But now we are learning like system wise, and at the end of the course we get the helicopter view.
Exactly.
Yeah.
So that change sort of affected the way people experience autopsy. So it's much less experienced, especially at the medical student level. Retention of organs also has changed a lot since, 100 years. If you look at, we used to keep, actually not 100 years, you go back 20 years, we used to keep a large amount of tissue, especially 4 rounds. So the medical students would come in that are signed up for the pathology course. The next day, all the organs would have already been in formalin, and so risk of disease is minimal to none. And they would have been prepped and washed, and so we would have like 20 medical students at a time, and they would look at the whole autopsy. Timing of consent, that's another issue, is that usually the timing, like death, doesn't take an appointment. It comes when it comes, and so sometimes it's 2 o'clock in the morning on a Monday, and many times the person on call would be a junior, or and the difficulty in getting consent or explaining to the family what an autopsy is always going to be the difficulty, because maybe that physician or junior physician never attended, and so it becomes very difficult to explain to someone something you've never seen before. So that just explains, Osler is one of the famous Canadian physicians that worked in, or helped, actually they helped start Johns Hopkins, and later also worked in Oxford. And then, so in his time, physicians would perform the autopsy. Not only, at the time, I don't even think pathology had started. And my professor, when I first started, Dr. Chamberlain, he used to be, as a medical student, used to attend autopsies. But now, most medical students will never have attended an autopsy. And same with many of the residents, except in pathology, obviously. And so times have changed and the education has changed. So what is the future directions? This is why we're here today. That was just the introduction. Why are we here? So currently, what do? We do histology, as like slides. We do microbiology cultures. We do toxicology, so chemical analysis. Immunohistochemistry, electron microscopy, like in kidney diseases, and molecular and clinical genetics. And we do banking if it is consented, on the consent, if the family agrees, we can bank tissue for future tests if needed. So I'm not talking about politics or anything, but I think that as an advocate of the dead, I say we should make autopsy great again. Why? Because of the benefit to the patient, to the community, to vital statistics, to teaching. And in the end you can see with your own eye, but I don't mean any political or any kind of political issues or problems. Has nothing to do with it. I just thought it looked good for autopsy. But how we're working now, the pathologists and the physicians are not in sync, I find, with the future for different reasons. And I think that issue affects the postmortem or the autopsy itself. The reason I use P, because that's the path forward. So pathology is our department. So the path forward, right? So everything starts with a P. So what is the future of pathology, or future of autopsy, sorry? So can this help us with the workload? Because there's a huge workload for pathology. How are we, just like family medicine, if you probably read in the papers, or in emergency departments, how they're affected, right? So how can we decrease the workload so that we can perform better? Can we use any kind of technology, any kind of development to make pathology or make autopsy more efficient, right? So are we replacing for safety or for diagnosis, right? So many people would say that would be a good idea for safety reasons, meaning that even in new diseases, we wouldn't have to use PPE, right? We don't even maybe need to be in the room. And then, can that help our diagnosis also? So safety is a big issue, workload is an issue, and diagnosis is an issue. Can future diagnosis be better, faster, and can it store the diagnosis, right? So, what is postmortem imaging? Let's see if that works. I hope it works. If I click on it, and we might have to see a commercial. Oh, we don't have to. Nice. Yeah, so, and I think this is in Zurich, and they have managed to create a digital camera that can do the external examination and map the body. Remember when you asked about, can we do it? See, that's how you're thinking outside the box, and maybe also because of your, I think, neurology or neuroscience background. And so, so here, not only do they do it electronically, but it's the camera doing it for us, documenting even the exact site of where these changes or injuries or disease is with the camera itself. So it's not only electronic, it's actually the computer doing it for you, right? And in the end, you have a complete picture of that stored. So it's not like you documented it and if you missed it, it's gone. You can always go back and see it. And in addition, it maps it. So if you needed to take a biopsy, you can choose the area. So it's doing surface scanning, and then you can choose a certain area and tell it to take a biopsy from that area, right? Then it also goes through a CT scan. So now you have the external mapped electronically, and you have the internal mapped also. And it can tell you the relationship between these. And it will reconstruct the body, and you can see it in any way you like, from inside or from outside, without any incision. This may be good for safety issues if you don't know what the disease is. It could be a good thing for increasing number of autopsies, but not overwhelming the department. So you could choose some cases that would be only electronic. Or maybe you could only biopsy certain organs, right? I think the other part...
So could this job be replaced by robots?
Could it?
Be replaced by robots?
I think so. I think so, but not in the current way we're doing it, but I wonder how to go back to my presentation.
So, let's see.
Where would it, what does Apple do to my presentation?
Do anything, it's still there, so, let's see, where did we begin? So, all right.
I wonder if it's in the back right here.
In my mail, yeah. No, so we began in my mail, that's where we,
Oh, that means we have to start from the beginning.
no, we just go to where.
Oh, there it is.
Yeah.
Where are you from?
Where am I from originally? It's a long, you want the long answer or the short answer?
Whatever you like.
I'll just say I'm from the Middle East.
Okay.
Yeah, that's the short answer.
So you can go to the slide that you
Oh.
want, right?
You know, I think this is the last slide. Is it not? Oh, there we are. Is it this? Yes. And so,
Right,
robot
and
assisted
then
surgery.
go to slideshow.
Yeah.
Yeah.
Oh.
Yeah.
Oh, and so that's one way, and then the other way would be, so that's thinking of like directly replacing a human, right? So saying that we're going to use CT or we're going to use a robot to do the same thing a human would do. The other idea is that we already have a device, but what kind of ethical issues would this device bring? Because if you put a device like a watch, whether it's on your arm or an implantable device like a defibrillator or a pacemaker, so if we have devices already that pacemakers, diabetic monitoring, in the future we may have devices that can record other vitals, right? And it can tell us almost maybe in the future what every organ is doing all the time. And would people accept that? So not just your heart rate, your weight, your height, your rate of breathing, your oxygenation, maybe it will monitor every single organ. And it will tell us that you're dying or dead. Maybe it will call 911. It will tell us what organ is malfunctioning, but all the time. And what kind of not consent, but privacy issues or invasiveness would this be? Will humans accept it or not? And so that was my thought on that. I think the last thing is, so if we can incorporate future technology, that will increase safety, diagnosis, and as far as accuracy and speed of the diagnosis. It will help prevent these same diseases within families or the community, so if it's infectious or if it's inherited, right? So you can spend more time, or maybe we're going to decide every heart will be biopsied with this robot. And then we can bank and we can test all Albertans for heart disease or different genetic diseases related to the heart. So that would be, the issue would be record versus privacy. How would we deal with that as a community? But I think if we start thinking about that today, we may be able to incorporate that, and then we work together so that the postmortem will continue to give us vital information. And so I always I like this part. I don't know if Edmonton found me or I found Edmonton. But as an autopsy pathologist and a person that feels that I speak for the dead, right? I feel that Deadmonton, although it was as a slur, and some Calgarians may use the term in a way that we dislike. But I think, just like this haunted house in Edmonton said, you know what, we're going to use that. I think we should use it, and we should be the #1, futuristic autopsy unit in the world, and claim Edmonton as a badge of pride and honor, and not as a term that we dislike. Yeah, thank you very much. I hope you benefited, and go Whalers. and thank you in every language that Google knows.
Wow.
Yeah,
Cool.
yeah. I don't know if you can find something that you, other than English, that you can read there, but
Sri Lanka. Obadastuti.
is it? Yeah.
Yeah.
Maybe it's either this. No.
Yeah.
Ah, that's the one.
Yeah. That. Yeah.
Oh, that's the rest of it.
Yeah.
Yeah.
The second row on the middle.
Yeah.
Great. So, I've been encouraging students in this class to think about their relationship to AI. Most young people across the world, have decided not to use AI as a tutor, just to let AI do everything for them, and then they take the credit, right? And so you can find videos that reassure you that, like, in the future, you'll never be alone. You'll always have this AI companion, and so on. But just as the autopsy of human biological tissue is important, what you can accomplish with your own brain with the AI turned off is also important. So I see kind of a relationship between interest in the autopsy and human disease, and interest in what your own brain can do. And if you're proud of that, you should turn off the AI from time to time and see what creative work you can do. And that then gives life meaning. What meaning does your life have if everything you've ever done that's notable, AI really did, and you took the credit, right? That's a life without meaning. So if you turn off the AI every now and then, then you have meaning. And what about if your brain isn't good enough to provide entertaining content? Then you can borrow it from other content providers. So it doesn't have to be from AI. It can be famous musicians, poets, writers, So I think I'm trying to instill in the students here kind of pride in what their own brain can do, and discouraging them from just giving up and letting AI do everything. Because in the future, AI will be able to do everything. That doesn't mean that you should just stop thinking, right? Yeah. And so the same kind of curiosity that makes one interested in the autopsy should make you interested in what can my brain do? How does it compare to what AI can currently do? Like, AI is not uniformly better than humans yet. It will be soon. But you kind of have a window where if AI produces something, you could maybe make a better version. You can outpace AI at the moment. In another 3 or 4 years, you won't be able to. But, yeah. So it's interesting. I've been pushing that, and you can hear me on videos from this course talking about it. And thus far, no student in the course has said, yes, you're right, and so on. But I have found some young people out there who feel this is a good message to disseminate. And it's a huge problem. I mean, not just at our level of teaching, but in elementary school and so on. The kids so early get the idea that their phones can do everything. And therefore, why should I learn anything? Why should I gain any skills when I don't need to? Because the AI can do everything for me. So I think we would like to push back against that idea and have people be proud of their humanity and what they can uniquely accomplish. Yeah.
I think even as kids, when we were not allowed to bring a calculator to school.
Yeah.
I know it's not AI, but calculator can give you the answer, like when you were in elementary school. But I guess maybe in neurology or neurosciences, I think, I'm not sure how the brain grows or the brain matures or the brain becomes smarter, but I do feel that if you know math, it's better than relying completely on a calculator. In the same way, I think I would agree with Dr. Solis regarding having both worlds and having them complement each other instead of replace and wipe out each other.
But you see, you and I are old enough to value solitude. I think these 5 young people in the room may never have experienced that.
True.
Right? That there's always like music playing in their headphones, sounds being made by the people around them, and maybe it would be scary if they have solitude and the only noises are the ones you yourself produce. They may never have experienced that.
It's a very interesting discussion because me and my friend were just talking about this recently, how we're all just banding together to go on social media and kind of realize that we can think for ourselves, which is really weird to say out loud, but we sit down all the time and we understand, like we see ads every day in front of us, we're putting our headphones on, we're not thinking for ourselves. And like some people journal, that's the way they can like connect with themselves, but again, like not a lot of people in our generation really realize that until maybe around this point where they're like, oh, I'm constantly being surrounded by things. I need to realize that I need to start thinking for myself because I am my own person, and people lose themselves in the fact that there's so many things they can see, but they don't know who they are at the end of the day.
Right. So, you know, the motivation for such things is so much greater in 2025 than it's ever been before. Because before, there were all these things that we valued. Nobody even argued it. We valued science and medicine and research and so on. And now you'll find that people are just saying, well, those things were a waste of money, you know, and let's see what happens without them, right? So, yeah. So there's more to prove now about what you yourself can do. And one person can or multiple instances of one person changing the world is still possible. You can do that. And the idea of planning your life by taking someone else's life who you know and say, well, I'm going to be like that person, I think that is kind of like the dumbest thing to do, because then you're judged immediately that, you know, you didn't pick up things quite as fast as the other people in the field and so on. And, you know, the competition may be crushing, but there are all sorts of reasons to think that there are brand new things to be, to do, to aspire to that's nobody's trying. If you're the first to try it, then nobody's going to judge you. Nobody's going to get any criticism flowing, because however well or poorly you do that, you're still the best person in the world doing it if you're the only one doing it. And that's still possible. And a lot of traditional roles probably don't make sense, and new ones that you might identify. We need this and nobody's doing it. Yeah. So I used to say that this course had survival value. What I meant was, in the distant future, when the future comes, you know, you'll be more familiar with what's going on, because one or more of the things that we teach in the course will actually happen in the future. But it's more tangible and near, right? It isn't like years away. It's like a few months from now, a year from now. You know, things are going to happen that are very surprising. You suddenly, they're talking about, you know, nation states of AI. Right now we have nation states of people. But now in the future, in data centers, you'll have these nation states of smarter than human AI, just as consequential as the actual nation states of people. And yeah, and you can just wait and see what happens and be passive victims of the future, or you can actually make the future by doing something new that needs doing that nobody's ever done before. That's still possible, tangible, multiple ways in which you can do it. Like, think about Don. He never told us really why he came from Sri Lanka here. I mean, he met Arthur Clarke there. Yeah. Why didn't he just stay there? Right? But he sensed that Canada had, you know, opportunities that weren't there. Yeah, and when you look at the map, Sri Lanka is kind of far from.
Yeah, actually, like
places.
From Canada, it's like across the world. It's exactly 12 hours opposite side. Yeah, exactly. Like you have to go across the world.
Yeah, opposite both the east-west and north-south dimensions.
Yeah.
So like exactly, my parents are living like 12 hours across Canada.
Yeah.
But like I was into device development and all. Like I developed like few medical devices. I have a patented device called Don's mechanical CPR device. But when it comes to commercialization and all, like the country didn't have funding.
Oh.
And like I was in here, so I was presenting this thing everywhere, and like 6 countries gave me like scholarships, and the best scholarship I got from like University of Alberta. So now I'm in the Smart Network in University of Alberta, and my supervisor is Dr. Vivian Mushawa, who's the director of iSmart UFA.
So how would you feel about like the idea of like having a device?
Yeah. So
what's your opinion of having a device, and once somebody dies, we will already know what organ malfunctioned?
Yeah, so that's very important because I have a personal experience, because my research which I'm doing here is about deep vein thrombosis. So we know that deep vein thrombosis, like more than 50% of the cases are asymptomatic, and the most like serious complication of deep vein thrombosis is the pulmonary embolism, which is also can be asymptomatic.
Yeah.
So when I went to a little bit of a conference, I went to the stage and I started bragging about Sri Lanka, telling that it's like very less prevalent in Sri Lanka. And my supervisor like, oh, stop it right away. And she came and she told me, no, that's not the case. Third world countries do not do a lot of autopsies. Actually, when I was a doctor, we didn't do like when someone dies, we give the cause of death as cardiac arrest and we move on, because per day I am seeing 74 patients and we, rather than treating, actually we are doing crowd handling. So you can't go to a detailed autopsy and we don't document it, and the statistics are wrong. So that's why our hospital systems do not invest a lot of things on prophylaxis of deep vein thrombosis. Even IPC devices are not readily available in hospitals. So if they did the autopsies, if they knew this deep vein thrombosis and pulmonary embolism, if they detected it, they could have invested more money on this and prevent those deaths, right? So here we have the data, and we know that it's the third leading cause of the modern first world. So that's the discrepancy. So if we have a specific device to get the actual diagnosis of the cause of death, rather than going with the cardiac, cause of death, cardiac arrest, if we can define it, we can go into the policy level and implement specific money and prevent those deaths.
Exactly.
Yeah, that's the main objective. We try.
And so, not as a scientist or how would you feel personally or to the community if you have a device that can diagnose, let's say, PE?
Yeah.
Pulmonary embolism.
Yeah.
Would you use it yourself?
Yes, definitely.
Yeah.
Yeah. Not even pulmonary embolism now. If you can have a real-time ECG monitor.
Yeah.
And if you have a certain cardiac death, you can have a specific diagnosis and you can do a genetic assessment and see whether whether your genes predispose this condition. And if you have kids and all, you can educate them, right? You will have a certain cardiac death one day, so better to take a pacemaker early or a implantable defibrillator, so it can prevent a lot of deaths.
Do you think the community would accept these devices?
So anyway, it's highly personal, but I think majority are in the survival thing, right? So even when it's the COVID era, there was a anti-vaccine campaign, but
true.
So no offense, but some people classified it as natural selection.
Yeah, true.
So I think majority will go with the
device. Yeah.
Yeah, there will be a resistance.
Yeah.
But majority will accept it.
Do you think maybe the price of these devices right now is what's preventing
Yeah,
it from
so it's about the manufacturing and the government grants. Everything matters about the price. If it's if you manufacture few equipment and if it's not popular, the unit cost will be sky high. But if it's
mass
clonizing, mass production, and if the charity organizations, government grants and all, so that's why BP machines, blood pressure monitoring systems are very cheap, while an ECG machine costs a couple of $1,000. Because of the demand, right?
Does anyone have an opinion about either an implantable or wearable device that would?
Well, the iPhone, the iWatch has more and more features.
Yeah, so in my lab also, we are developing now the only the best real-time blood glucose monitor is an invasive one, right? Now the commercial ones are you have to pin it and it will monitor and it will release insulin. But now in my lab they are developing a sensor which is not invasive.
Just like the oximeter or the...
Yeah, exactly. But it should be really static when you get the reading, because it's very sensitive. So they are coming with the idea. So I'm trying, sometimes it will be my presentation as well. I'm trying to combine those two, the blood glucose monitoring and also the cortisol level, to determine the stress level of a man and how to balance this and reach the absolute happiness of life Like I have a project called Neurohappiness. So I'm coming up with that idea. So I'm collaborating with the MedWatch to get the accurate glucose level monitoring, because most people don't like to prick themselves.
Pricking, of course. Yeah, of course.
If it's non-invasive, it's great, right?
Yeah, of course.
So like, yeah.
So, you can think about it simply that life has changed in a way where just conforming and following an established path, that path could be easily interrupted by some politician's decision to pull the funding entirely.
Yeah.
Yeah.
Whereas if you start something new, like nobody would even know to target it, right? It sort of makes it Teflon, like you can't possibly interfere with this new thing that you're doing. And yeah, so I just encourage you to use the knowledge that you got in this course to, think about life a little differently, that you can rise to the top when everybody else around you is complaining because they're trying to pursue the kind of conformity life that you've always been able to do before, and it's not really working. But, think about another way of doing things. Yeah. So I think that's possible.
That's
okay.
fine for us.
Well, our 80-minute class period is over. Thank you again very
Thank you
much.
for having me.
Thank you so much. Thank you.
Thank you so much. I always enjoy to come to this course.